Well, good afternoon, everybody, and I'm stunned that so many of you are here still. Thought you'd have gone off after lunch, but never mind. So, thank you to Public Health Collaboration for inviting me to speak today. It's the first time I've been to any of these conferences, and I've really enjoyed it, so much so that I've become a member. So, there you are. So, I'm not a practitioner. I'm an academic, I'm a medical researcher, and I became a medical researcher quite late in life to try and help with my own health problems. And I did my PhD in an aspect of cardiology and went on to research, well, more in cardiology and also obesity, type 2 diabetes, and also mitochondrial research. So now I'm in the happy position of being able to research just whatever interests me. So in the last couple of years, I've been absolutely fascinated by COVID and the poor science that's been coming out about it, and more recently, long COVID. So here we are, long COVID. This led me to run an event in London in March, Long COVID Day. So I got together some really great practitioners who had all been very successful in helping their patients with long COVID. So I will be giving elements of their presentations, obviously with their permission, interspersed with a bit of science. So, what is long COVID, first of all? So, NHS England and NICE define it as signs and symptoms that develop during or following an infection consistent with COVID. Note, consistent with, you don't have to have had a PCR test to prove you've got COVID, which continue for more than 12 weeks and are not explained by an alternative diagnosis. So the 12 weeks is quite important then for the diagnosis, although there are other timeframes used in studies and other countries. So the government actually has done rather well on long COVID, and it's very nice to see that. They've given money for research studies. And indeed, we are running two of the largest surveys on long COVID. There's the Office for National Statistics, the ONS survey, which has been reporting 3 times a year, which is fantastic. This is based on the infection survey. And of course, there's a Zoe app study as well, which is based at King's College London, run by Professor Tim Spector. So that's been doing great work as well. So they've also allocated funding for long COVID clinics. However, this brings with it its own problems. Not all GPs have access to a long COVID clinic. And when they do get a patient on the waiting list, they're often waiting for many, many months. So this is not a very good situation. Some of these long COVID clinics only see patients who have been admitted to hospital with COVID-19. And as we're going to see, you can have long COVID when you've only had mild COVID-19 or possibly asymptomatic COVID-19. In other words, no symptoms at all. So this is why we felt that Long COVID Day, talking about alternative approaches to help these patients, might be really timely and useful. So all of these symptoms are recognised by the NHS as being long COVID symptoms. And actually, I think it's quite a good list. I think all the main ones are there. I'm sure we can all come up with a few symptoms that are not on this list, but it's not a bad starting point at all. Also, long COVID often presents with a cluster of symptoms. It's actually quite rare to just have one. Normally you have several. They can change over time, and they can affect any body system or organ. They can be continuous symptoms, or they can be remitting and relapsing. So that means it's Tuesday, so you've got all your long COVID symptoms. It's Thursday, you're feeling a lot better, so it's in remission. But it's Saturday, and you've got all your symptoms back again, and that's relapsing. So it can be either. And many of the same symptoms experienced during COVID-19, presuming that you had COVID, but there are new symptoms or diagnoses as well, which can come along. And particularly, we've got new onset psychiatric conditions and diabetes, which can be type 1 or type 2. And on the subject of new onset psychiatric disorders, we do have to ask the question. We may never know the answer, though. So diagnosing long COVID is very difficult because there are no GP tests for it. It's therefore got to be a diagnosis of exclusion of all other causes, which is reasonable. So the GP has to run blood tests based on the signs and symptoms that the patient presents with. That they will then refer to specialists as necessary or a long COVID clinic if they have access to one. So, 2/3, this is an international survey, 2/3 of those who'd undergone GP blood testing for long COVID reported normal results. So this led some to say, well, long COVID's all in the mind. But actually, I think it says far more about the tests available to GPs, frankly, which are not very broad in scope. And as you'll see, our practitioners have all found a way around this. Scanning can be helpful. Not so much X-rays, but MRI and CT scanning. And here's a study that found that even in asymptomatic patients, so here you've got PCR tests, so they're positive, but they've got no symptoms at all. MRI scans show heart problems in 78% of them, and myocarditis in 60%. So that's quite a surprise. But the important thing when you're going to see a GP with long COVID is that as long as you've got one of the symptoms on the long COVID symptom list and the GP has found no other cause for them, then the GP must diagnose with long COVID. And this is the advice from NHS England, from NICE, from the Royal College of General Practitioners, and also the World Health Organization. So this is actually quite good news for sufferers. And it's in stark contrast to the battle that chronic fatigue syndrome sufferers had to get that recognized as a condition. If you remember, it was yuppie flu in the 90s. Well, actually, no. So I mentioned the ONS survey, the most recent one, which came out in January of this year, and this is self-reported long COVID. What they do is they take a sample of the population and then they extrapolate it to the whole population. And they reckoned that 2.1% of the population could be living with long COVID. That's a lot. This is people having symptoms for more than 4 weeks. They didn't do the 12 weeks, this was more than 4. But of those who had symptoms for more than 4 weeks, 71% had symptoms for 12 weeks, and 42% had symptoms for at least a year. So that's not looking very good. If you look at the ONS surveys, you'll find that the prevalence of long COVID fluctuates according to which survey is used. This is perfectly to be expected because they sample different people each time. You're not getting the same people filling in the same survey. But you can't rely on any one set of numbers, is what it means. Fatigue in all of them was the most common symptom reported, followed by shortness of breath and then loss of smell or taste. And of the risk factors, it's age 35 to 69 and females. And this is in contrast, again, to severe COVID-19, which is males and the elderly. So that's quite interesting. These are the long COVID risk factors, which I put together from global studies. So they're all agreed that it's more prevalent amongst females, but there is no other clear consensus about any risk factor at all, except for high dose or prolonged use of steroids in acute COVID, which can predict long COVID development. So beware steroids. Duration of long COVID, well, this is the $64 million question, isn't it? And we don't know. I mean, to be fair, it's a new condition. None of the studies so far have looked at longer than a year, although we will soon be getting some for 15 months, 18 months. But worryingly, amongst those who do not recover within the first 5 to 6 months, nearly 50% of them have still not recovered at a year. So the moral of this is, get better quickly, because otherwise you may not get better at all. So I will be looking at other viral infections in just a minute to see if we can glean any idea from those of how long COVID really is going to last. So organs and systems affected, all of these. And as you can see, I haven't left much out. Why is this? It's because the virus gains entry to the cells via the ACE2 receptor. And the ACE2 receptor is expressed on cells in every one of these organs. So it's hardly surprising. And here's an international survey that found that the mean number of body systems affected per patient was 9. Now, given that that is an average, it means that something over 50%, under 50% still have more than 9 symptoms. They might have 11 or 12 organs and systems affected. So that is quite surprising. But it shouldn't be really, because of the ACE2 receptor. So I'm just going to say a few words about how the virus can affect the immune system in long COVID. So we've seen it give rise to quite a lot of autoimmune conditions. It can also give rise to inflammatory conditions, to the point where a lot of people are talking about inflammatory syndromes being a cause of long COVID. A syndrome is not a cause. It's a collection of symptoms and signs. It's not a cause. But inflammation does seem to be common to a lot of them. But on the other hand, you can get lymphopenia or lymphocytopenia. This is low blood lymphocytes. Blood lymphocytes are the white blood cells which generate all the virus-killing cells of the immune system. So low lymphocytes is a bad thing. It's immune suppression. It's like the body's saying, okay, I fought off the virus. I can't do it again. I'm exhausted. Right, so on to inflammation, I just want to point out two of the syndromes involved in inflammation, because this will come up again later. So systemic inflammatory response syndrome, this is the cytokine storm. This is the exaggerated defense response of the body to infection. Now, often it's very effective, but it can be dysregulated, and it can lead to end organ dysfunction, damage, and sometimes even death. But when the immune system is operating correctly, you've got a compensatory syndrome, which will kick in and dampen down the cytokine storm. And this is called compensatory anti-inflammatory response syndrome. So it really does do what it says on the tin. So this is the counterbalancing response and generates immune suppression. Now, I'm sure you can all see a danger with that. So it's very important that you get a delicate balance between these two. And a properly functioning immune system will give you this balance. But if there's a problem with the immune system, then you're liable to get the cytokine storm, which will not be damped down easily. Other viruses that have post-viral effects, well, all of these. I was quite surprised to see how many. And when you look at this list of diagnoses, you can see that it's very similar to the sort of things that you're seeing with long COVID. Most of the studies are being carried out on SARS-CoV-1. So SARS-CoV-2, that's the virus which is supposed to be responsible for COVID-19, this is a very close relative of SARS-CoV-1, which is the original SARS back in 2003, now tending to be called SARS-CoV-1. And every virus listed on the previous slide had fatigue as one of its most common symptoms. So we shouldn't be surprised at that either. Long COVID duration in these other viruses, well, it's not good news, I'm afraid. Lung lesions decreased from 9% at 1 year to 3% at 2 years, but had risen to 5% after 15 years. Here's cardiovascular events, very high risk in the first year, and still high risk for the next 10 years. Fatigue, 3 to 4 years after recovery, 40% reported persistent fatigue, and 27% met the CDC criteria for chronic fatigue syndrome. This is the Centers for Disease Control in the US, and their criteria are quite stringent. So 27% had chronic fatigue syndrome. So let's move on to what our great practitioners had to say. So breathing difficulties, first of all, from Dr. Damien Downing. So he noticed a lot of evidence accruing that long COVID patients were breathing shallowly through their mouths and into the upper chest, whereas what they should be doing is breathing through the nose and down to the diaphragm. Why? Because diaphragmatic breathing stimulates the vagus nerve, and this helps to regulate heart rate and the nervous system. And a lot of the symptoms of long COVID are nervous system driven. And he quoted a study, for which I don't have a reference, I'm afraid. These are patients with breathing difficulties giving yoga exercises for a week. And every one of them had improvement in shortness of breath and fatigue. So that was quite good. So he's got some tips here on how to stimulate the vagus nerve. I must say the opera aria sounds rather nice. Sorry, neighbours. Other measures for long COVID, he's worked with a patient group, which you can look at here. And they did a survey of their members to find out what supplements they were taking that had actually worked. And they came up with this list, of which they found that niacin was the most helpful. And as we're going to see in a minute, it improves energy production. But the people who did everything came out best. So there's a starting point for you. And by the way, I've summarized all the remedies on my final slide, which I'll leave up for a bit. So you don't need to jot things down now. So the next one is Dr. Sarah Myhill talking about poor energy delivery mechanisms. And I've given you her website here because you're probably going to need to refer to it. It's extremely informative and tells you all kinds of things about, well, almost everything really, except the meaning of life, but there you go. So if you've ever heard Dr. Myhill talk before, you'll know that she likens energy production in the body to the working of the engine of a car. Now, I've reliably been told by an engineer that this is rubbish, but never mind. It works as an analogy for me. So she says, put the correct fuel in the tank, this is the diet, maintain the mitochondrial energy to burn the fuel, support the accelerator, which is the thyroid gland, and support the gearbox, which is the adrenal gland. So the fuel in the tank, she recommends a paleo-ketogenic diet, and in fact, she's written a book about it. But it is also on her website. And the mitochondria, she recommends sleep, testing and removing toxins, for which patients would need a practitioner. And these are her mitochondrial supplements, all of which are excellent. So that's really quite helpful. Thyroid function. Now, she thinks GP blood tests for thyroid are rubbish, but she does recommend getting antithyroid antibodies tested, particularly if there's a family history of problems, and also checking that there's no reverse T3, as that can block the functioning of T3. You can get this done at Biolab or the doctor's lab in London. But she relies on temperature testing, and she's got a lot about this in her book and also on her website, which is all quite interesting. If there's a problem, here's her thyroid support supplements. But she does recommend doing this through a practitioner to avoid over-supplementing, which can be quite dangerous with some of these. And there's her book, which is excellent, actually. I do recommend it. And it gets my prize for the best title of It's Mitochondria, Not Hypochondria. Brilliant. So the adrenal function, GP blood tests will never show any of this. She relies on temperature testing again, but you can get saliva or cortisol or DHEA saliva tests. And chronic fatigue syndrome patients, and presumably long COVID fatigue syndrome patients too, have low cortisol and low DHEA. This is fairly unusual in our high-stress society. Most of us have very high cortisol, but fatigue patients, low cortisol and low DHEA. So she recommends removing the stressor and using adrenal support supplements, for which, again, she recommends a practitioner. So mitochondria was also mentioned by Gillian Crowther, so that she also thinks the thyroid is probably involved here. Her supplements are iodine, selenium, and copper, but again, do use a practitioner for this because too many minerals or the wrong balance can do more harm than good. Low carbohydrate diet, definitely. Red light therapy, she swears by. And here are her mitochondrial supplements, which you will have mostly seen before anyway. Medium chain triglycerides, possibly not, but you can get this through Amazon. She also talked about iron dysregulation. She noticed that patients can have hyperferritinemia in long COVID, but their iron levels can be normal. So if you go to a GP and say, I think I've got hyperferritinemia, they'll test the iron and it'll come back normal, and the answer will be, oh no, you don't. What you need to do is test ferritin levels. So for this, you need a practitioner. But it's worth doing because untreated, it can lead to hypercoagulation, which is a problem in long COVID. These are her supplements for that. Also enzymes, and this is for the hypercoagulation, and pycnogenol to open up the vasculature, and a herb to chelate excess iron. Of course, if you do have excess iron, probably the simplest thing is just to donate blood. You're also doing somebody some good then as well. Then we had Professor Robert Thomas talking about the gut. He'd just run a randomized controlled trial on probiotics and phytochemicals, which he'd just had published, so that was very nice. But first of all, he started off by talking about the studies showing depleted healthy strains of lactobacillus in COVID and the need for prebiotics. Now, as well as the reasons he's given here, I would also add that if you give a probiotic, it's transient. It's not going to colonize the gut. It's going to do some good, for sure, but then it's going to be excreted. What you want is to increase colonization with good bacteria. For this, you need prebiotics. And to my mind, this is the primary reason for taking prebiotics. And he's helpfully given some prebiotic foods here. And of course, you can get prebiotic powder from most good supplement companies. Here's his trial. Now, what he did is he took two groups with long COVID gut symptoms, and he gave them a probiotic, and then one group he also gave a phytochemical capsule. He didn't mean to run the trial like this. What he meant to do was to take one group and give them the phytochemical and the probiotic, and the other group got nothing. They were just the control. But he realized that word of the trial had got out, and people in the control group were rushing out and buying their own probiotics. So as he said, okay, we can't have this. So he ended up giving the control group the probiotic anyway. So now we don't have a took nothing group. We're just testing the phytochemical, really. Anyway, it certainly had some good effects. 2-fold reduction in fatigue, 3-fold reduction in cough, and a more than 2-fold improvement in overall well-being. That's on the phytochemical alone, so that was quite good. So here are the phytochemical and the probiotic components, and you can see they're all good. Lots of good academic evidence to support all of this. And the probiotic has vitamin D, which is great, and it also has a prebiotic as well. All good. And you can buy it yourselves. I've given you the website there. So then we had Dr. Yassine Bendi Abdallah, and he recommends baseline supplements with immune support for anybody with long COVID, which comprises a multivitamin. You have to check carefully to make sure there's no supplementary iron in there, because there could be. Vitamin D, omega-3, zinc, and green tea extract. And then he noticed that some patients have mast cell activation syndrome. This is something you've never heard of. It's a condition where the mast cells release too much histamine, basically. which is what is the problem in hay fever, for example. So you think you get allergic symptoms even though there's no allergen present. And he quoted somebody in a paper saying this is similar to calling in the whole SWAT team over a coffee spill at Starbucks, which I think is quite a nice analogy. So what you need if this is suspected, and there's a lot of online information, by the way, about mast cell activation syndrome. So you need mast cell stabilizers. So among the natural products, you've got luteolin and quercetin, which are the two main ones. Vitamin C, also very good, resveratrol. And you need H1 and H2 blockers, which you can get in a regular chemist because of the hay fever symptoms. H1 is I think H1, no, never mind, I'm not going to speculate. Mitochondrial dysfunction, he also mentioned. So those are his mitochondrial remedies. I think those we've all seen before, except possibly glutathione and N-acetylcysteine, which are good mitochondrial remedies. Disturbed sleep, anxiety, inflammation. Well, I think we all have that, don't we? So those are his remedies for that. All of these are readily available, although melatonin is supposedly a prescription drug, although I have to tell you, you can get it quite freely from a company called Biovia. So that is good news. And gut support. Butyrate, which is a short-chain fatty acid, very good in the gut. Zinc carnosine, which heals leaky gut, therefore very helpful, and probiotics again. Then Gillian Crowther and Dr. Ziggy Trefzer also talked about reactivated infections. So Gillian had seen a lot of patients who had reactivation of other viruses, Epstein-Barr and cytomegalovirus in particular, but she also saw some enteroviruses. So, oh, what have I done? No, wrong button, sorry. Right. Now, if you think you want to test for this, it's fairly easy to do. You just go on the Academy of Nutritional Medicine website. Gillian, incidentally, is Director of Research for the Academy of Nutritional Medicine and does some great work there. You can also find a practitioner if you're a patient. So the tests are all done through a German company called Armin Labs, who are very good and reliable and have come up with some really excellent and helpful results. So that's all good. And these are Gillian and Ziggy Trefzer's remedies for reactivated infections. A few new things here. They're mainly antivirals for the cytomegalovirus, the other herpes viruses, the echovirus. Other than that, I think you've seen most of those before. And reactivated infections is an issue which I'm going to come on to now, because I finished off my lectures on long COVID day talking about mechanisms underlying long COVID. Because there is no consensus as yet as to what this might be. But I went through a lot of the studies and collected information on this and put this chart together showing the most likely mechanisms. And it's entirely probable that you've got about 4 or 5 of these mechanisms running at the same time. It's not going to be one or the other. But I'm not going to talk about them all now. I'm just going to talk about virus reactivation. So that's the SARS-CoV-2 virus in a viral reservoir and reactivation of other dormant viruses from viral reservoirs. So viral reservoirs are collections of virus-infected cells which are hidden from the immune system. And these have been found in long COVID full of SARS-CoV-2. They've been particularly found in lymphoid tissue, and amongst the lymphoid tissue, particularly in the gut. You might know we've got gut-associated lymphoid tissue, or GALT, which is where most of the viral reservoirs are. The same place you also get reservoirs, incidentally, for HIV. And there are several reports of relapse or reactivation of SARS-CoV-2 in these recovered patients. And if you remember, when the pandemic was still quite new, and before we got variants, we had talk of people being infected twice. They mainly made the newspapers because this was quite surprising. I don't think they were infected twice. I think what it is, and other scientists have come to this realization as well, what it is, they were infected the first time, the virus hid in a viral reservoir, because the immune system was depleted, it got reactivated. So the same one, but not from outside, from inside. So reactivation then, here's a meta-analysis which estimated that around 12% of all recovered patients who tested positive for SARS-CoV-2 reactivation. 12%. We don't know which of those have long COVID, because that wasn't what the study was about. But still, 12% of recovered patients test positive for reactivation. That's quite amazing. And a number of studies have shown that reactivation of the other dormant viruses can contribute to severe COVID-19. So you've got the infectious stage, which is SARS-CoV-2, and then it's thought that amongst those who have to be taken into ICU and put on ventilators, that is where another virus has kicked in. So that's quite interesting. I'm sure we'll be hearing more about that later. So reactivation of any virus from a viral reservoir can only come about when the immune system is dysfunctional or it's suppressed. So either you haven't been taking your vitamin D, or, do you remember I talked about CARs, dampening down the inflammatory response? If that's overdone it, you've got a suppressed immune system, or the immune system may simply be plain exhausted. So this is a very interesting study, which is the only one that I found so far that appears to successfully predict long COVID. So let's have a look at this. So these are individuals who had mild COVID, so they were not hospitalized, mild COVID, and here's 3 to 4 months after symptom onset. So in those who didn't suffer long COVID, they had a coordinated innate and adaptive immune activation, the inflammatory cytokine signaling, as it should be, and strong interferon responses. And the immune and the inflammatory response quickly subsided. So you had SEERs and then you had CARs to compensate. That's the immune system working as it should. But in the patients that did develop long COVID, you didn't get the interferon response in anything like the way that it should be. So consequently, you get a prolonged inflammatory cytokine signaling, and you go on to develop long COVID. So admittedly, this is a preprint study. It's not been peer-reviewed and published in a journal yet. But I think this is a very interesting study, and I shall be following this one to see what happens to it and to see if anybody else publishes anything similar, because I think this points the way to the future. So, interestingly, SARS-CoV-2 actually restricts the action of interferon. So never mind the state of your immune system when you catch the virus, SARS-CoV-2 works against it anyway. It limits interferon production. It generates several proteins that evade the type 1 interferon response. There are several types of interferons, but it's type 1 that we need active here. And it disables a protein called tetherin, which is an antiviral restriction factor. So even with a good immune system, the virus is working against you from the start. Happily, there's a lot that can be done about that. So interferon can be given as a drug, but unfortunately it has some rather nasty side effects which are similar to long COVID, so that's not very helpful. But you can raise interferon naturally by all these remedies, most of which you'll already have seen. And there's something very important which is not on that list, and that's vitamin D, because there's a huge amount of evidence to show that vitamin D does actually raise and facilitate the action of interferon in the body. So that's the most critical thing, which is not only good as a treatment for long COVID, but also could prevent it. So if I've succeeded in interesting you in Long COVID Day, you can actually buy the recording. You just email Biolab on the email address given there. And in fact, you can also buy our previous event, which was Mitochondria Day. This was looking at mitochondrial dysfunction in chronic disease. We covered metabolic disease, cardiovascular disease, neurodegenerative disease, cancer, and autism. So, but Mitochondria Day is not for the faint-hearted. There's a huge amount of science, so just to warn you there. And I have no financial interest in whether you order the recording or not. So just to say. And here is the list of remedies, which I've already mentioned. Thank you.